Humanity's victory over smallpox is a reminder of what's possible when nations come together to fight a common health threat. Many of the basic public health tools that were used successfully then are the same tools that have been used to respond to Ebola and to COVID. Disease surveillance, case finding, contact tracing, and mass communication campaigns to inform affected populations. The smallpox eradication campaign had one crucial tool that we don't have for COVID-19 yet: a vaccine. In fact, the world's first vaccine. As you know, WHO is now working with many partners to accelerate the development of a vaccine for COVID-19, which will be an essential tool for controlling transmission of the virus. But although a vaccine was crucial for ending smallpox, it was not enough on its own. After all, the vaccine was first developed by Edward Jenner in 1796. It took another 184 years for smallpox to be eradicated. The decisive factor in the victory over smallpox was global solidarity. At the height of the Cold War, the Soviet Union and the United States of America joined forces to conquer a common enemy. They recognized that viruses do not respect nations or ideologies. That same solidarity built on national unity is needed now more than ever to defeat COVID-19. Stories like the eradication of smallpox have incredible power to inspire. But there are many more untold stories about health around the world. Next Tuesday, the 12th of May, WHO will announce the 5 winners of our inaugural Health for All Film Festival. The winning films were chosen by a distinguished panel of jurors from almost 1,300 entries from 110 countries. The shortlisted films can be seen on WHO's YouTube channel, and we invite everyone to join us on our social media channels next Tuesday for the announcement of the winners. Yesterday, I announced the resources WHO estimates it needs to deliver our updated strategic preparedness and response plan for COVID-19. The updated plan estimates that WHO requires $1.7 billion to respond to COVID-19 across the 3 levels of the organization between now and the end of 2020. This estimate includes the funds that WHO has already received to date, leaving WHO's COVID-19 response with a funding gap of $1.3 billion for 2020. To be clear, this estimate only covers WHO's needs, not the entire global need. WHO is deeply grateful to the countries and donors who responded to WHO's initial strategic preparedness and response plan, and to the hundreds of thousands of individuals, corporations, and foundations who have contributed to the COVID-19 Solidarity Response Fund. And we thank you so much for your commitment and support. Our updated strategic plan takes into account the lessons we have learned so far, strengthening WHO's role in global and regional coordination. It's built on 5 strategic objectives. First, to mobilize all sectors and communities. Second, to control sporadic cases and clusters by rapidly finding and isolating all cases. Third, to suppress community transmission through infection prevention and control and physical distancing. Fourth, to reduce mortality through appropriate care. And fifth, to develop safe and effective vaccines and therapeutics. To support these objectives, WHO will continue to provide technical, operational, and logistics support to countries, and we will continue to update and adapt our guidance according to local needs. In certain fragile settings and countries with weaker health systems, WHO will continue its operational work as a provider of essential health services. As we reflect today on the eradication of smallpox, we're reminded of what is possible when nations come together to confront a common foe, to confront a common enemy. The legacy of smallpox was not only the eradication of one disease, it was the demonstration that when the world unites, anything is possible. If there is a will, there is a way. It gave us the confidence to pursue the eradication of other diseases like polio and guinea worm. Like smallpox, COVID-19 is a defining challenge for public health. Like smallpox, it's a test of global solidarity. Like smallpox, COVID-19 is giving us an opportunity not only to fight a single disease, but to change the trajectory of global health and to build a healthier, safer, fairer world for everyone. To achieve universal health coverage, to achieve our dream from the establishment of WHO in 1940s, health for all. And I thank you. But before we move on to questions, Tariq, I would like to mention one small way we are commemorating the eradication of smallpox. When WHO's smallpox eradication campaign was launched in 1967, one of the ways countries raised awareness about smallpox was through postage stamps, when social media, Twitter, Facebook, was not even in the horizon. To commemorate the 40th anniversary of smallpox eradication, the United Nations Postal Administration and WHO are releasing a commemorative postage stamp to recognize global solidarity in fighting smallpox. I especially want to thank my friend, Mr. Atul Khare, the United Nations Under-Secretary General for Operational Support, for making this commemorative stamp possible. Thank you again, Tariq, and back to you.
Thank you very much, Dr. Tedros, for these opening remarks on this very remarkable anniversary day. I forgot to introduce speakers today, but I think you know them already. It's Dr. Mike Ryan, Dr. Maria Van Kerkhove, and we have Mr. Steve Solomon, who is WHO Principal Legal Officer. We would also like to thank interpreters who are with us today, helping that journalists can ask questions in their language. So we will start with questions now. Please be short, concise, one question per person. And we will start with Deutsche Welle, and we have George. George, can you hear us?
Yes, sir, I can hear you.
Yes.
May I ask, French scientists have found that cigarette smokers are less likely to be hospitalized with COVID-19. What do you make of these findings?
Thank you very much, George, for this question.
Thank you very much for the question. So we know the harms of tobacco are well known, and we know that millions of people die every year from the use of tobacco. COVID-19 is a respiratory illness, and smoking causes damage to the lungs. And there are a number of studies out there that have been published that have found that smoking leads to more severe disease, the development of severe disease, and puts people at higher risk for being put on a ventilator, being in ICU, and for dying. There are some studies, there are some media reports of some studies, 2 studies in particular, that have not been peer-reviewed, that have looked at the prevalence of smoking in people who've been hospitalized and not. These studies did not evaluate, they were not designed to evaluate whether smoking was protective or not, or in any shape or form. And they do not say that smoking is protective. We do know, I will repeat that we know the harms of smoking, and we know that smokers, if they do get infected with COVID-19, have a higher risk of severe disease and death.
Thank you very much, Dr. Van Kerkhove. Next question comes from Guatemala. Guatemala Diario de la Hora, and we have Grecia on phone. Grecia. Thank you very much. I think we understood it now.
I can start, and perhaps Mike would like to supplement. So we're just beginning to see now a number of countries that are opening up their economies after having shown that they are able to suppress transmission. The countries that are further along in this are countries across Asia. And we do see that countries like China, Japan, Korea, Singapore have lifted some of these public health and social measures in a slow and a controlled way. In some countries, they have seen a resurgence in cases, meaning that they've seen some outbreaks. And in Japan and in Singapore, for example, they've seen outbreaks that are taking place in certain situations. Singapore right now is dealing with outbreaks in expat dormitories and dormitories where people live in close proximity to one another. And they just shared a presentation with us earlier today demonstrating how they are going into exquisite detail in terms of trying to find all of those cases and suppress transmission even in these closed settings. What we are learning from those countries who are slowly opening up their economies again, and we've talked about this before, once these measures are lifted, they need to be lifted in a very slow and controlled way because it's possible for the virus to take off again. Countries are improving their systems to identify the virus, identify people who are infected with that virus through increasing their testing capacity, through increasing their ability to do contact tracing, where they're making sure that the beds in the hospitals are free so that they can care for patients depending on the severity of their systems. So what we're seeing is even though they are lifting some of these measures, they are quickly working to find cases if those cases do resurge, so that they can try to suppress transmission again. I think we're going to be in a situation where we may need to lift some of these measures, but be ready to quickly identify those cases. There may be sort of a push and pull for some time as we try to really work and suppress this virus across the globe.
Thank you very much. Next question is for our friend Geneva-based journalist Peter Kenny, representing South Africa media. Peter, can you hear us? Peter, can you unmute yourself, please? Do we have a Peter Kenny? If you really need to unmute yourself. Otherwise, we will try to come back to Peter maybe later. Let's try with Bianca Rotier from Globo, Brazilian media. Bianca.
Hi, Tarek. Can you hear me?
Yes, please go ahead.
Thanks a lot. So, my question is about Brazil. I'll make it in Portuguese. O governo brasileiro disse que não está conseguindo receber os respiradores que já encomendou. Eu sei que a OMS já se comprometeu com testes e com equipamentos de proteção. A OMS planeja ou pode ajudar o Brasil também com respiradores? E eu gostaria de saber a posição, a orientação da OMS em relação a eventos privados. Por exemplo, o presidente Jair Bolsonaro planeja fazer um churrasco para cerca de 30 convidados. Qual é o risco de eventos assim? E, de maneira geral, qual é a preocupação da OMS em relação ao Brasil? Um editorial da revista científica Lancet lançou um alerta com uma estimativa de que a taxa de duplicação do número de mortes seja de apenas 5 dias. Thanks.
That's about 5 questions in one, so I think it's going to be difficult to address. WHO always responds to requests for assistance from member states. And I think it's important to clarify here that the WHO is an agency made up of its member states, and we respond to any request for assistance from those member states. We're not entitled or empowered to come into any country, provide any specific standards or guidance, or to deliver any particular material unless we're invited to do so by the government of that country. And I'm sure that the government in our American regional office, the Pan American Health Organization, and we will respond promptly to any request for materials, supplies, technical assistance, or strategic guidance regarding the nature of mass gatherings or any other control measure that Brazil wishes us to do so.
Thank you very much. And yes, please, if we can have one question per journalist, that would be really good. The next question is coming from Greece. That's Kostas from ERT Television. Kostas, please unmute yourself and we will be able to hear you.
Hello to everybody. Thanks for taking my question. Since the beginning of the pandemic, states have been called upon to identify cases and test citizens. PCR and antibody tests are already in use. Lately, we have been observing groups of researchers analyzing city wastewaters to determine the degree of contamination of areas by coronavirus. Can this innovative tool give us a faster and more realistic picture of the pandemic versus the usual tests? Thank you.
Kostas, if we can just repeat the question is about the new tests, antibody tests, or?
No, it's a question about analyzing cities' wastewaters to determine the degree of contamination of areas. Can this give a faster and more realistic picture of the pandemic?
Thank you very much for that.
So I could start, but maybe Mike will want to add. So yes, sorry, I didn't hear the question before. So there's a number of ways in which we are looking to evaluate how the virus is circulating globally. You mentioned two of those, the use of molecular tests or PCR tests, which are measuring active infection in people. There's the use of the antibody tests, which are also testing people, but that's testing past infection. We have a unit here that's looking at wastewater, that is looking at if the live virus or fragments of the virus are found in wastewater. We do understand that there are fragments of virus. This is not live virus or infectious virus that can be found in wastewater. So it's possible that that might be something that could be used to look at where the virus may be, but it's important that we focus our attention on looking for the virus in people. Countries have demonstrated the ability to, if you aggressively look for cases, human cases, and find those individuals, isolate those individuals, care for them depending on the severity of their illness in a healthcare facility or at home if that can't be done, and identify all of their contacts and quarantine those contacts. We know that that works and that can stop transmission.
If we could, maybe just emphasize that point. I think we've said this a couple of times. I mean, science and discovery is very important, and looking for the virus in different samples have been able to find different ways to monitor the presence of the virus, be it in environmental samples, very important, in antibody tests in recovered patients, very important. They all have an importance, and they're all very important for understanding the long-term trajectory of the pandemic. But we seem also to be avoiding the uncomfortable reality that we need to get back to public health surveillance. We need to go back where we should have been months ago, finding cases, tracking cases, isolating people who are tested positive, doing quarantine for contacts. We have seen time and time again in countries that have contained this virus and brought it under control without the need for massive lockdowns, have done it through the application of principled, human rights driven, but sometimes quite aggressive public health surveillance. And I think we sometimes, and I think this is something we do in society, we sometimes look for the answers where they're not. We need to go back to the basic principles of how we control this disease. A comprehensive strategy that matches basic public health surveillance, community, education, knowledge and empowerment with a strengthened healthcare capacity to treat cases. And we are able to pull those three things together and develop a vaccine in the medium to long term. That's the core. There's a lot of other information and science that needs to be discovered around that, but we need to stick to the core strategy, or else we really will risk looking for answers where the answers are not, or the answers to the questions we're asking are not going to solve the problem we have. We know the problem we have.
Thank you very much, Dr. Ryan and Dr. Van Kerkhove. Now we will go to Laurent Sierra from Swiss News. Laurent, can you please unmute yourself? Yes, please go ahead.
Yeah, thank you for having my question. Since you raised the question of the sero tests last time, the Swiss pharmaceutical group Roche got the approval from FDA, and they pretend to have a product which is trustful than 99% and more efficient. And at the same time, there was a study by the University of Zurich published in The Lancet that tend to show that COVID-19 is not only a pneumonia, but also systemic vascular inflammation. So what does these two components tell us, and what might that change in terms of response? Thank you.
I'll start with the first part of that question. So there are hundreds of tests that are available. A number of them are serologic tests, which are measuring the amount of antibodies in an individual. And some of these are undergoing different forms of validation, which is very important. This means that each of the tests that are developed are assessed and evaluated for how well they work. And there you use a known quantity of sera, of biological material, to look and see how well the tests perform. Do they actually measure what they're supposed to measure? And that's important. We are working with a number of labs and also FIND to help do validation of molecular tests as well as serologic tests. And as those validation results come available, then we will have more and more confidence in each of these tests that are out there. There are more than 90 countries that are currently conducting seroepidemiologic studies. We've mentioned that previously. And this is an important part of understanding the extent of infection in a population, in a country, and across the world.
And on the issue of the clinical syndromes associated with COVID-19, I think this is an important issue, because I think we've very often seen with new emerging diseases that they don't always have just one target organ. They tend to cause a much more disseminated disease. They may affect multiple organs. And it is sometimes only over time, many, many generations of transmission, sometimes decades, sometimes hundreds of years, where some diseases establish what looks like a preferred organ, or it becomes an endemic disease with one organ that's affected more than any other organ in the body. And we tend to often call those diseases after the organ they affect. We often call the hepatitis viruses because they cause hepatitis, inflammation of the liver. But there are many different types of virus that cause that same problem. But however, there are diseases like measles, and we often think of measles as a disease, a fever with a rash, a mild self-limiting illness in children. I can tell you that measles in an unvaccinated child who's undernourished and living in a refugee camp is a serious disease that can affect their lungs, their eyes, their brain. It can cause so many different organs to fail. It's quite frightening. So I think when we look at COVID-19, we need to see that as a disease that obviously is a respiratory disease. It's spread by a respiratory route. It causes a respiratory syndrome. It is clear that in a proportion of patients, it is causing a broader inflammatory response, either within the vascular, or that's the blood-carrying system, or in other parts of the body. We've also seen reports of encephalitis, or swelling or inflammation of the brain. We've seen other reports other effects of the disease. And that's why it's so important, as Maria has said previously, that we continue to collect clinical data from across the world on all of these different impacts of the virus. But it's still primarily causing a respiratory syndrome, and you see that, unfortunately and tragically, repeated day after day in intensive care units around the world, patients struggling to breathe with their oxygen levels falling and having demonstrable damage by CAT scan and X-ray to their lung tissue. That is a major part of the syndrome, but clearly the vascular effects, or the effects on the blood-carrying system or the cardiovascular system, are there, they're real, and they need to be studied further.
Thank you. Next question is from David Andelman from CNN. David, you have the floor.
Yes, thank you. Can you hear me?
Yes.
Good. Can you suggest why Russia's infection rate has been rising so dramatically, and whether the WHO figures really reflect the totality of Russia rather than largely Moscow, and whether Russia is following WHO guidelines for containment, as Dr. Tedros has just outlined?
Thank you, David.
I think Russia is probably experiencing a delayed epidemic, and we've seen this in many contexts. We've seen how Italy was one of the first countries in Europe to experience a large-scale epidemic, and it was followed by Spain, followed by the UK and others. And we believe that in that sense, Russia has experienced a delayed beginning to the epidemic and is now seeing that increase in cases. Russia has also increased its testing both in the urban areas and outside them, and the increased numbers may reflect partly that, but there's also been an increase in deaths, which means the disease is clearly having an impact. And I think the government has really shifted its response into a much more aggressive mode over the last week or so, because I think there's a growing realization that this disease is requiring a scaled up response. In terms of the strategies been implemented, Russia has implemented fairly large-scale public health and social distancing measures. It is increasing its lab testing across the country. I think where all countries have struggled, quite frankly, is with systematic contact tracing, particularly when numbers begin to rise very quickly. And I think this has happened. If you remember, we spoke about the 4 C's before, where you have cases and you have clusters, and then you have this widespread community transmission. And I think when you have cases and clusters of cases, it's quite straightforward with some targeted investment in public health services to do the kind of containment activities we've spoken about before. Once you reach intense community transmission, it becomes very, very difficult at that point to do systematic and comprehensive surveillance. I think the exceptions to that are countries like Korea, that managed to do incredible contact tracing in the middle of a very intense community outbreak. So it is possible to do, but it requires a very coherent, very well-resourced and a very well-trained public health workforce with a lot of resources and the support of government and of the community to achieve that. And I think that's maybe for Russia, for other countries in Europe, once you get behind the curve and once the disease has spread at community level, the only options that have remained open to countries in those situations have been pretty severe public health and social distancing measures. And those measures have had an impact, and they have suppressed infection. But and as those numbers have fallen and restrictions are lifted, the danger is always, as Maria has said before, of a jump back. That disease will probably jump back unless you continue suppressing the virus by those public health measures, by those cluster investigations, by that contact tracing, that testing, and by continuing to support the community to maintain physical distance and appropriate measures, if not a total lockdown. With the case of the Russia, I think Russia is just in a different phase of the pandemic and can learn some of the lessons that have been learned at great cost in Asia, in North America, and in Western Europe.
Thank you, Dr. Ryan. Next question coming from Maya Plants from The Shift. Maya? You need to unmute yourself, please.
Yes, thank you very much for taking my question. My question is still regarding the cardiovascular issues that have been reported. If you could elaborate a bit more on how are you looking at these issues of, patients report, how does the WHO reports on this and collects data on this because I heard that some people came to hospitals not with respiratory problems, with cardiovascular problems, and then they went back home, and later they were found out that was part of the symptoms that they exhibited by being, having cardiovascular issues.
So thank you for the question. It's a really important question. As we learn, as Mike has just said, as we learn more and more about this virus, I have to remind myself that we're in month 5 of this pandemic. And although it has seemed like an incredibly long time, we're at the very, very early stages of our understanding of how this virus affects the body, how disease progresses, what diseases that this infection causes. We have a global clinical network that we've brought together. We bring this same group of clinicians across the globe together for other diseases. We activated this group very early in January to bring together clinicians who have experience with treating COVID-19 patients. And the value in doing that is you're putting clinicians talking to clinicians with firsthand experience of what they are actually seeing in terms of the patients, medical professionals, what those patients are dealing with to save their lives and to try to prevent them from progressing to severe disease. The way in which we gather information about symptoms or disease is through a standardized set of data that needs to be collected from patients. It's very difficult to collect a standardized set of data from patients when you're in the middle of a very intense outbreak and you're just trying to save as many lives as you can. But in some countries, and in many countries that don't see intense transmission right now, and especially in the beginning, what we did is we set up a clinical case report form, which is something that was developed with WHO and ISARIC, which is the International Severe Acute Respiratory Infection Consortium, and many partners, many clinicians and nurses and medical practitioners across the globe to set up a case report form that collected a set amount of data from each patient. And in doing so, that helps us gather information so that we can analyze it and say, is this common? Is that not common? Is it associated with COVID-19 infection? What does the presence of smoking or an underlying condition have to make that condition worse? So we set up this case report form. It is being used now. It took some time to get going, and there's more than 10,000 case records in this. And we are hoping that more and more case records can be obtained so that we could better understand this. In addition, we're working with a number of countries who are conducting their own studies in their hospitals. Some of these are coming out through peer-reviewed publications, but those are done by individual hospitals. And that information is really critical for us to gather an evidence base to really understand what's happening. But with these syndromes, with these new syndromes that we hear about, those are identified by astute clinicians, astute nurses, astute medical professionals. And it's important that that's characterized. You've heard of this hyperinflammatory syndrome in children. That is something that is now being looked at by clinicians. This is among children, a very rare condition that seems to be among children. This is being looked at globally now. And there will be a case report form specifically for that so that we can collect standardized information and be able to understand this disease further.
Thank you, Dr. Van Kerkhove. Next question is from Al-Arabi Al-Hadath. We have online Doha Al-Zuhairi. Can you please hear us?
Yes, I can hear you. Can you hear me?
Please go ahead. Yes.
Okay. So my question is about any promising cure or vaccine, especially that we heard reports about showing negative side effects on patients who use hydroxychloroquine, and now eyes are on remdesivir. So any updates concerning that?
So I can start on this, and Mike or Gigi may want to supplement. So there are hundreds of clinical trials that are currently underway looking at different therapeutics, different drugs that could be used for COVID-19. What is important is that any of these potential therapeutics need to be evaluated properly through what are called randomized clinical trials to ensure that whatever agent is used provides safe and effective treatment. You mentioned side effects. So it's not only important to look at how well this works against maybe preventing infection or helping someone progress to more severe disease or preventing death. It's also very important that it doesn't have side effects. So there are a number of clinical trials underway. We have initiated with partners the Solidarity trial, which is a clinical trial that is evaluating a number of therapeutics, including remdesivir, including chloroquine. And there are more than 2,500 patients that have been enrolled in this clinical trial from, I think, 15 countries so far, but there are more than 100 countries that are willing to participate in this clinical trial. And the beauty of this is that by doing a clinical trial across multiple countries and across multiple hospitals, is that we can have enough patients to be able to evaluate the answer to which drugs are safe and effective quicker. And so as of right now, we don't have any drugs that have fulfilled all of the criteria through these randomized controlled trials, but it is incredible that there are so many that are underway, and we look forward in the coming months to finding out more about which drugs are safe and effective for COVID-19.
Next question is for Antonio from EFE News Agency, Spanish-speaking news agency. Antonio? Antonio, can you please unmute? Let's try one more time with Antonio.
Sí.
Hello. Thank you. My question is about social distancing measures in the opening up phase after lockdown. Do you think we'll be going through months or even years before people can actually hug or kiss each other again or shake their hands even? Thank you.
Yeah, I think that's you reflect our fervent desire of all human beings to reconnect with each other. And we share that sentiment here. We haven't shaken hands or hugged our friends in 18 weeks either. Or seen our families, some of us. And therefore it's really important that we work hard to get back there. But we need to be careful. We've seen what this virus can do in situations where the virus has spread unstopped. So yes, I think there is a pathway out, and I think many countries are taking a very careful, stepwise approach, relying on the patience and perseverance of their citizens to continue to suffer what is a difficult process, both socially, psychologically, and economically for many people. But I think everyone is doing that because we want to protect those we love, and we want to ensure that we end this as quickly as possible. So we're going to have to monitor this very carefully. We are, and as WHO, we are monitoring. We've tried, and it's very difficult, but we've tried to work out the whole selection of measures that have been put in place by countries, and as those measures are lifted, we're looking at which countries are taking away which, and we will monitor the epidemiology in those countries, and with them we will look at and examine if certain measures as they're lifted may cause a jump in cases. We'll have to think about that again, one being the schools is a very good example as people return to work. I think the thing, and I think we're seeing, is that a careful and measured return to those kind of normal activities of work and school, especially if they're done with density reduction, physical distancing and hygiene in place, seem to be very prudent and practical. Where we're going to maybe have to accept a little bit more time is going to be around mass gatherings, things like large-scale gatherings, concerts. We're coming into the summertime in Europe, North America and other places in Asia. And this is the time when people gather en masse. We go to big events, and it's going to be much more difficult to make those perfectly safe. And life is life. There's no zero risk. We all have to, we do it every day. We manage the risks in our lives. And what we need to do collectively is reduce the risks associated with COVID transmission to an absolute minimum, and then recognize what risk is left and be able to mitigate that risk. And we would, at this point, in countries where we see downward trends in disease, where we see a strong public health surveillance in place, where we see a healthcare system that's capable of treating cases, where we see a committed community willing to continue with personal and community measures, I believe there's a path out. But it may involve schools or partial school opening, partial workplace opening, those working from home that can, those that need to go to work, being properly protected in place. And especially those people who have to work in high density conditions, we have to make special provision for their occupational health and safety. Then we have to look very carefully at events that bring people together en masse. And see how best we can bring, for example, we spoke the last day about football and other spectator sports. Maybe the sports can start again, but the spectators may have to stay away for a little bit longer. So, and I think everyone has a stake in this. This isn't just the purview of scientists. This is a dialogue with communities. This isn't just science spitting out orders that then are implemented by people. There is community activities and social life is a dynamic process. And there needs to be a good dialogue. And we need to have that at national level. We need to have that at provincial level. And it needs to be had at local level. Communities are very often best placed to look at what's important and look at what's relevant for them, but always with risk in mind and listening to the science and listening to the public health advice. So yes, I'm sorry, I've been long-winded in my response because I think the issue is so important. There is a path out, but we must remain ever vigilant, and we may have to have a significant alteration to our lifestyles until we get to a point where we have an effective vaccine and effective treatments. But that doesn't mean it's all bad. I mean, we've seen some benefits to our environment. We've seen some benefits to our connectedness. Strangely enough, even though we've been disconnected physically, I think many of us have recognized how important those connections are. So I think we need to move forward recognizing that it's been and is and will be for many populations and countries with weak health systems. Still, this is a big challenge, and we're not through it yet in many countries. And as some countries come out of lockdown and come out of these measures, they can offer hope to communities who are entering into epidemic situations. Learn lessons from what everyone has done, transfer resources, and help other countries to fight the fight they have to fight. And in the end of this, as Dr. Tedros says again and again, through solidarity, we will win the fight, and nobody is safe until everybody's safe.
Thank you, Dr. Ryan. We can take a couple of more questions maybe before we conclude. Now we go to India, United News of India with Ajit.
Yeah, thank you. Thank you so much. My question is related to temperature range. That is there any study, any experiment, or any lab research that what is the temperature range that this virus can survive within the human body as well as in the open environment?
That is a very good question and a very specific question, and I don't have the data in front of me. There are studies that have evaluated virus survival on different types of surfaces, on wood, on steel, on fabric, that have found that the virus can survive hours to days, depending on the temperature and the humidity. I don't have the details of the temperature and humidity off the top of my head, so I will be very happy to provide that answer if you get the name and the contact information. But what we do know is that the virus, if it is on a surface, can be inactivated, can be killed with disinfectants. in a matter of minutes. And that is important. And it is important that people know that because if they do touch a surface that is contaminated, they can wash their hands or use an alcohol-based rub and protect themselves, or they can clean their surfaces regularly. So it's important that surfaces are cleaned regularly and that you wash your hands. But I'll have to get back to you on the specifics of the temperature and humidity.
Okay, and just, I think one important point, because you mentioned two things, one about environmental situations, and you also mentioned body temperature. Body temperature this is important for people in terms of, because I've heard various stories about people saying that it's important to be very hot or be very cold. This has no impact on the virus. Viruses and infectious diseases cause people to have fevers, and very often it's the breakdown products of the virus or the immune response that trick the body into being hot. And having a temperature in itself is not necessarily a bad thing, but also that temperature has to be carefully monitored, especially in children. So the idea that one should have a very high temperature and that's helping to get rid of the virus is not true. The body is responding to the virus's presence. Equally, the idea that you would try to cool someone down to get rid of the virus is not true. But there are certain situations where there is a high temperature, and it's important for doctors and nurses to get the temperature down, because very high temperatures, and I mean very high temperatures, can be associated with convulsions and other effects. So the monitoring and the management of temperature in a person who's got an illness is very important. And it's very important that clinicians can manage a very high temperature. But the idea that temperature itself is affecting the way the virus will behave in the body is not true. So people managing themselves by trying to make themselves very cold or make themselves very hot will not affect the process of the virus in your body. But managing the temperature is very important for the outcome for the patient.
Thank you. Maybe we go to last question. That would be Politico, and it's Carlo who is with us tonight. Carlo?
Yes, hello. Thank you for taking my question. I had a question about the different rates of the virus geographically. For example, even in Europe, we see very different rates in Eastern Europe versus Western Europe, and sometimes even within the same country. For example, the north of Italy versus the south of Italy. Do we have any idea what's causing this extreme variability even in small geographies?
If that was the last question, we could be here all night, because you know, it is, and it's an important question, but it's not one that one can answer in a single sentence or in a number of sentences. But it does go to the heart of some of the issues associated with the transmission of this virus. I mean, obviously the virus transmits in different situations with different degrees of intensity. And what we've seen in mass gatherings or situations where people have been pulled together in large groups, we can see an amplification of disease that can seed disease in the community very quickly, therefore generating a very large wave of infection. And in some situations we have very small waves, and the number of infected builds up more slowly. And that can occur because of a particular type of event that sort of triggers the transmission in a large number of people in a community at one time. But it can also happen because of the conditions that a community live in. The number of people who live in a household can often affect that. The transmission of, for example, disease in somewhere like Sweden versus somewhere like Italy may just as much be affected by the fact that 50% of Swedish people live alone in apartments or live in apartments of less than 2 people, whereas many people in Italy socially live in much larger households. I'm not saying that's the reason, but you have to look at population density, you have to look at the way people live, you have to look at the way they interact. And that may be affecting the way disease is transmitted in many countries. You have to look at the way in which people use public transport and use transit. If the large proportion of people are using overcrowded transit in the middle of a respiratory epidemic, you will see more transmission. So you could look at any number of factors. Population mobility between areas. In some countries, mobility between areas is not very high. in other countries, mobility, long-range commuting has become very common in Europe, for example. It's not unusual to find people commuting between countries to go to work. So social, economic, behavioural patterns can affect the way in which disease spread, population density, population behaviour, social norms, and the way we live our lives in general. There are differences right now, as I said before, between Western Europe, which has been through that first big wave, and Eastern Europe, particularly the Russian Federation, that is now experiencing higher numbers of disease. And I was answering the question previously about Russia. I'd forgotten to say that there'd nearly been about 450,000 tests carried out in Russia, which puts it about, when you do it for the number of tests per million population, is around 30,000 per million, which of the 57 countries in the European region of WHO puts Russia about the 10th highest of all the rates of testing. The positivity rate is about 3.6%, which again is quite low compared to the positivity rates in other countries. So in that sense, just to follow up on the previous question, the number of deaths also remains very low as a proportion of the overall cases for the Russian Federation. So, but you see that, you can clearly see that the number of cases has risen in somewhere like Russia. And what we have to be very careful of is that the death toll doesn't rise with those cases. The other factors around the world, I was speaking in a European context there, so many other factors driving the risk of transmission in countries. The degree of compliance with public health and social measures, the availability of effective public health response like contact tracing. We've seen countries who've been very systematic with a very comprehensive strategy. I think of countries like New Zealand who've really done the lot, and they've gone from public health measures to a very graded response to very systematic case finding and contact tracing to a high rate of testing. When all of those factors have been put together, the disease tends to be more controllable. So disease epidemiology is driven by the natural history of the virus, it's driven by human behaviour, and it's obviously affected by the public health or the health response to the virus. So it's very hard to make hard and fast rules for what happens in any individual country. Maria?
Thanks. I just want to touch upon one aspect of this. The virus is transmitted through the respiratory route. It's transmitted through infectious droplets from an infected person to another individual who's in close proximity to that person without wearing protective gear, or through contaminated surfaces where you touch a contaminated surface and you inoculate yourself through touching of your eyes or your nose or your mouth. The parameter that we look at to really evaluate how fast and how quickly this virus could spread is called the reproduction number. And that number is the average number one infected person individual will infect. If that number is above 1, then the virus can take off and you can have an epidemic. If that reproduction number is below 1, it will die out. And so what we're looking at in a number of countries is that they're constantly evaluating is what is the reproduction number, and they call that the time varying reproduction number. That number is context specific, as Mike was saying. If you prevent people from coming in contact with one another, if you isolate known contacts so that they don't have the opportunity to be in contact with someone else, if you find the contacts and you quarantine those contacts, and they do become cases, they don't have the opportunity to infect other people. You actually break the chain of transmission, and the virus has nowhere to go. The virus needs a person to be able to transmit to another person. If we are able to break those chains of transmission, we can bring that reproduction number under 1. And it's very context specific. Even I brought up Singapore before, but even thinking of what's happening in Singapore, they were able to bring their outbreak under control until the virus had an opportunity to start in a closed setting, where you have people who are living in close contact with one another. These types of closed settings exist in all countries. in long-term care living facilities, in institutions, in prisons, and we need to find ways in which we can prevent the virus from transmitting from one person to another. And that way we can bring that reproduction number under one, and we can break those chains of transmission. This is the first pandemic in history that we can control by doing these measures. Find, isolate, test, treat, find all of the contacts, quarantine those contacts, engage your populations, have them know what they can do to protect themselves and protect others.
Thank you very much. So we will conclude, and I apologize to journalists whose questions have not been answered this time, but obviously we will have other opportunities. The audio file will be sent in the next hour or two, and transcript will be available tomorrow. I wish you a very nice weekend to all.
Yeah, thank you. Thank you, Tariq. Thank you for joining us all online, and have a nice weekend.
Hello to everyone watching us on various WHO platforms. Also welcome to all journalists joining us through online connection for this regular press briefing from WHO headquarters in Geneva on COVID-19. Before I give the floor to Dr. Tedros, I will just remind you that the question and answer session will start immediately after, and that question should be one per journalist and very concise. We do have an interpretation as we had in the previous days. We also have sent you a number of products from different WHO offices on different topics. So I will start by giving floor to Dr. Tedros.
Thank you, Tariq. Hvala. Good morning, good afternoon, and good evening. First of all, I would like to welcome all Hindi-speaking journalists, and we look forward to your questions. In total, WHO press conferences are now available in 8 languages, all 6 United Nations languages, plus Portuguese and Hindi. Namaste. Plus closed captions for people with hearing loss. More than 3.5 million cases of COVID-19 and almost 250,000 deaths have now been reported to WHO. Since the beginning of April, an average of around 80,000 new cases have been reported to WHO every day. But these are not just numbers. Every single case is a mother, a father, a son, a daughter, a brother, a sister, or friend. Although the number of cases reported from Western Europe is declining, more cases are being reported every day from Eastern Europe, Africa, Southeast Asia, the Eastern Mediterranean, and the Americas. However, even within regions and within countries, we see divergent trends. Every country and every region needs a tailored approach. But the impact of the pandemic goes far beyond the numbers of cases and deaths. Around the world, the pandemic has caused severe disruption to essential health services, including to community-based health care. Also, professional health workers, like doctors and nurses, play crucial roles in many countries trained members of the community play a vital role in delivering essential health services like vaccination, prenatal screening, and the detection, prevention, and management of many diseases. Today, WHO, UNICEF, and the International Federation of the Red Cross have published guidance for countries on how to maintain community-based healthcare in the context of COVID-19. It includes practical recommendations for countries on sustaining essential services at the community level, leveraging community health workers for the response to COVID-19, while keeping them safe, and advice for how to adapt services for specific diseases and age groups. For example, it suggests using telemedicine wherever possible and leaving insecticide-treated nets for malaria at the door of households instead of asking people to collect them from a central location. It's also vital that countries pay careful attention to the most vulnerable members of their societies. Crisis can exacerbate existing inequalities, which is demonstrated in higher rates of hospitalization and death among certain populations in many countries. We must address this now and in the long term by prioritizing diagnosis and care for those who are most at risk. This is not only the right thing to do, it is the smart thing to do. We cannot end the pandemic until we address the inequalities that are fueling it. Today's guidance complements the United Nations Framework for the Socio-Economic Response to COVID-19, published last week. The framework lays out a recovery roadmap for countries to protect lives and livelihoods. I repeat, lives and livelihoods, and get businesses and economies up and running again as soon as possible. Importantly, the framework takes a health-first approach, recognizing that strong and resilient health systems must be the foundation of recovery in all countries. As more and more countries consider how to ease the so-called lockdown restrictions, I want to reiterate the 6 criteria that WHO recommends countries consider. First, that surveillance is strong, cases are declining, and transmission is controlled. Second, that health system capacities are in place to detect, isolate, test, and treat every case and trace every contact. Third, that outbreak risks are minimized in special settings like health facilities and nursing homes. Fourth, that preventive measures are in place in workplaces, the schools, and other places where it's essential for people to go. And fifth, that importation risks can be managed. And sixth, that communities are fully educated, engaged, and empowered to adjust to the new norm. The risk of returning to lockdown remains very real if countries do not manage the transition extremely carefully and in a phased approach. The pandemic has highlighted the importance of strong national and subnational health systems at the foundation of global health security and universal health coverage. Strong and resilient health systems are the best defense not only against outbreaks and pandemics, but also against the multiple health threats that people around the world face every day. And yet, on current trends, more than 5 billion people will lack access to essential health services by 2030, including the ability to see a health worker, access to essential medicines, and running water in hospitals. Gaps like this don't just undermine the health of individuals, families, and communities. They also put global security and economic development at risk. The world spends around US 7.5 trillion on health each year, almost 10% of global GDP. But the best investments are in promoting health and preventing disease at the primary healthcare level, which will save lives and save money. Prevention is not only better than cure, it's cheaper and the smartest thing to do. The COVID-19 pandemic will eventually recede, but there can be no going back to business as usual. We cannot continue to rush to fund panic, but let preparedness go by the wayside. As we work on responding to this pandemic, we must also work harder to prepare for the next one. Now is an opportunity to lay the foundations for resilient health systems around the world, which has been ignored for long. That includes systems to prepare, prevent, and respond to emerging pathogens. If we learn anything from COVID-19, it must be that investing in health now will save lives later. History will judge all of us, not only on whether we got through this pandemic, but also on the lessons we learned and the actions we took once it was over. And then before I end, I will just repeat something that I said many times. The antidote for this pandemic is national unity and global solidarity. Together, we will defeat COVID-19. I thank you.
Thank you very much, Dr. Tedros, for these opening remarks, and we do indeed welcome Hindi speakers to our press conference. Again, we are working with Zoom that has particular technical modalities. So, for example, Arabic speakers need to go under Korean language if they want to choose Arabic language, while for Hindi speakers they have to go to Japanese language. So hopefully this thing will get better as we move forward. Also, for the time being, Hindi speakers can only listen, and then questions will have to be said in English, but we also work on that. In any case, it's very good that we can reach to more and more people. So before we go to question, I would just like to remind everyone that we need to be very concise and one question per person. So I'll just check with my colleague Chris who we would have first in line, and let's go with Ankit from India today. Ankit, you have the floor.
Good evening. My name is Ankit Kumar. I represent India today. My question is on contact tracing applications. More and more countries are rolling out their own versions of these applications. Is there any data or study, or can you tell from your own experience, if these applications are helpful in controlling the pandemic threat? In your opinion, should these apps be mandatory for those going out on work during the lockdowns, as the case is in India? Thank you.
Thank you, Ankit. This was about contact tracing applications.
So I could start, and perhaps Mike or DG would like to supplement. So thank you for the question. Contact tracing remains one of the fundamental tasks that need to be done to help control transmission of COVID-19. And what we mean by contact tracing is when you identify a case through your surveillance systems, that you identify all of the contacts, all of the people who are in contact with that known case, and then you follow them over 14 days. Your question was specifically about apps, and apps can supplement the work that needs to be done by people. The work that needs to be done by individuals who can go out and actually interview cases and find out who did they come in contact with just before they became symptomatic and while they were symptomatic before they were isolated. And that needs to be done by a group of individuals, and many of them are trained in epidemiology, but you don't have to be trained in epidemiology. We've seen many countries use different workforces, volunteers who are trained, school teachers we've heard of students who can help with this contact tracing. And what's important about an individual, the people that do this, is that you need to find cases through personal interaction and through interviews, all done physically distanced, of course. The apps can help, but they don't replace people who need to do that contact tracing. And what we're seeing is a lot of apps and a lot of applications that can help find people who may have been around somebody if they're using smartphones within a certain distance, and that can help narrow down the number of contacts, but it doesn't replace the individuals who actually have to go out and do the contact tracing.
Yes, just in supplement, there are different applications out there, and many countries have developed them, many consortia have developed them, and in academia and the private sector. There are apps out there that help people learn about the disease, and there's some very useful apps out there that provide better information about the disease and good information, and that also, in some cases, help people check their symptoms. In other words, allow people to get information regarding the symptoms of the disease, check their symptoms, and see if they should take further action. There are also mobility tracking applications where people doing modelling, and you've seen that with IHME in the US and other modelling institutions, where in the background they're checking the overall mobility of the population, which helps drive the modelling and prediction of disease. Because clearly, if people are more mobile and mixing more, you can use that to make your model more accurate about the likely future incidence of the disease. And then there are the apps that can help with contact tracing. And that's the many countries, the UK, I think, have just finished testing their app. What that app allows public health authorities to do is to, number one, potentially, and Korea have a similar application, is help with the tracing process. Once someone is sick, what would normally happen is they'd be tested and isolated. As part of that process, the public health authorities will ask them about who they've been in close contact with in the previous days. And that is a difficult process, remembering exactly who you spent a certain amount of time with in certain settings to see who the high-risk contacts might have been. A way to supplement that is to have an ability to use mobile phone technology that can actually remember, in a sense, for the person, because your mobile phone can remember who you were close to in the last number of days, and it can actually calculate how long you've been close to that person. So what it does is it provides an aid to memory for that process, and that can be very good. It can also be used to notify those contacts that they have been in contact with a confirmed case, which allows them to take appropriate action. For all of this to obviously work, it involves the Bluetooth function on people's mobile phones to be activated and people to accept that they wish to use this application. And I think that's where we have an opt-in process, many countries have an opt-in process for that. Each country is using a slightly different application with slightly different opt-in or opt-out processes. And obviously, countries have to take very good care of the fact that tracking people's location needs to be done for the sole purpose of COVID-19 response, and that is something that is being discussed actively in each country. From our perspective in WHO, We are working with many of these developers around the world and looking at these applications and then trying to establish applications or bots that we can offer to countries who they can adapt for their own use should they wish to. A good example of that is the Go Data application, which is a contact tracing system that allows countries to maintain a very sophisticated database of contacts, cases, lab results, and allows public health authorities to construct transmission chains and manage the whole process of contact tracing. We have made that application available to all countries, and many countries are now using that as a way of managing all of the data around cases. That does not involve individuals' mobile phones being tracked in any way. That's just purely to aid the process of contact tracing and the process of integrating all of the data. And one of the weaknesses in this whole response, or one of the challenges, has been how do you integrate data from the hospital, data from the public health system, data from the lab. And you've seen the frustrations when people say, we don't have the data, or where is the data? Very often the problem is that different parts of the health system are generating data for different purposes, and that data doesn't come together in a way that helps drive the response, and it takes time for that to happen. So applications that are assisting with that are extremely useful. So I would just like to clarify, it isn't one app, it isn't one way of doing things. Each and every one of these applications needs to be looked at by national authorities and to see how the app can help them do a better public health job of testing, tracing, tracking.
Thank you very much, Dr.
Merci beaucoup à tous les deux. La question suivante.
Следующий вопрос. Anatolia News, турецкое агентство. Байрам, слышите ли вы нас? Байрам, пожалуйста, включите свой микрофон. А сейчас слышно? Пожалуйста. Спасибо за возможность задать сегодня вопрос. Наша турецкая футбольная федерация объявила о том, что примет у себя финал Лиги чемпионов. И сейчас у нас приостановлены соревнования. И были проведены некоторые матчи в мае без зрителей. Мы знаем, что у вас есть контакты с УЕФА и ФИФА. Какие рекомендации вы можете сформулировать футболистам по возобновлению матчей в Европе? У нас есть конкретное руководство по массовым мероприятиям в отношении всех спортивных мероприятий и как нужно ориентироваться на риски. То, как прислушиваться к этому, это суверенное право федераций и правительства, которые проводят у себя подобные мероприятия. Вы привели, конечно, пример конкретный, связанный с футболом. Футбол, да, такие соревнования бывают и со зрителями. И...
Pour assurer la sécurité des différentes personnes. Donc la question est de savoir quels sont les risques, comment est-ce que ces risques sont gérés, et ensuite quel est le processus qui nous permettra d'y parvenir. Et donc je crois qu'il faudrait avoir des informations spécifiques pour la Turquie, pour l'Allemagne, et pour voir quelles sont les mesures de limitation des risques qui ont été adoptées. Et je pense que si les gouvernements, les fédérations de ces pays nous posent la question, eh bien nous sommes tout à fait prêts à leur donner à la fois nos conseils et nos avis. Merci.
Thank you very much, Dr. N.
Большое спасибо. Насколько я понимаю, у нас возникли проблемы с стримингом на некоторых языках. Надеюсь, что мы будем в состоянии решить нашу проблему. Давайте перейдем к следующему вопросу.
Be fixed soon. So why don't we try with CNN contributor Michael Bosurkiv. Michael, can you hear us?
I can hear you. Can you hear me?
Yes, please ask your question, and we are trying to sort out the issue with the languages.
It's all right now, actually. The problem's been corrected. Thank you.
Thank you for taking my question, and greetings from Vancouver Island. Dr. Tedros, Prime Minister Trudeau was one of the last world leaders to indicate that he'd like to examine the timeline for the declaration of the global public health emergency. And I wanted to ask you, in 2015, an independent panel of experts that included members of the Harvard Global Health Institute and London School of Hygiene and Tropical Medicine, well, they recommended that WHO consider handing over its declaration responsibility and that there be establishment of a new global health committee within the UN Security Council. I'm wondering, given the criticism of the White House and concerns of other world leaders, would WHO consider a reform to that extent, at least to tamp down some of the concerns and criticisms coming from world leaders? Thank you.
Yeah, thank you. On assessments, I know WHO has a culture of assessing issues, and it has a process called after action review. And WHO actually wants any assessment more than anyone. And we will do the assessment when the time comes, and what we call the after action review. So we will see what happened based on the timeline when we do the assessment. But now I call upon the world to focus on fighting the fire, because while fire is raging, I think our focus should not be divided, and we should really focus on fighting the fire and saving lives. I thank you.
Thank you very much, Dr. Tedros. So next question goes to Penry People's Daily. Please unmute yourself if we can. Well, do we have someone from Penry People's Daily? Okay, so then we will go to the next one. Let's go to Jamil Chade, our friend based here in Geneva, representing a number of Brazilian press. Jamil, please.
Tarek, thank you very much. This is Jamil Chade. My question in Portuguese. So Tedros.
Dr. Tedros, my question is about the specific situation of the city of Manaus in Amazonia, which has a very high number of cases, and the prefect of the city is calling for international aid. And there's a great deal of concern on this issue in Amazon. And is there any specific aid from the WHO for Manaus and the Amazon region?
Please, Chief.
Yeah, as you know, we're working with the government of Brazil, so we will continue to work with them and address, or give any support they need. Thank you.
And if I may supplement that, on request of the government of Brazil, we've very often in the past worked at state level, and we've done that with yellow fever in the past on many occasions. So obviously, and we have a strong WHO country office there, or a PAHO country office, and we stand willing to provide direct technical support to any state through the process of a government request to do so.
If I could just add, it's not specific to Brazil, but just to say that in this new normal that we're in right now, where we're not able to travel, we're not able to get to all of the places that we would like to get to, we're finding new ways in which we can try to provide support to countries. And in some countries, we're doing these virtual missions where we have a set agenda and meetings where we're having these missions over Zoom, over Skype, over whatever platform that we have. But just to add that even if we physically can't get to a location because of the pandemic, we're finding different ways to provide support where that support is needed and as that support is asked.
Thank you very much. Next question is for Wall Street Journal. We have Lucas on the phone. Lucas, please unmute yourself.
Hello, can you hear me?
Yes, it's okay.
Okay. I think my question probably goes to Dr. Tedros. This relates to the upcoming World Health Assembly and whether Taiwan will be invited to attend. Would you encourage the member states, particularly China, to allow Taiwan to attend as an observer this year? And conversely, I understand that you have the authority to invite them yourself. Would you do that if China continues to resist their participation? Thank you.
Thank you very much, Lucas. And I apologize that I did not introduce our guest, our fourth speaker here. It's Mr. Derek Walton, who is a legal counsel of WHO. He is here with us, and I think he would like to take this question.
Thank you very much. And yes, of course, we have the World Health Assembly coming up on the 18th and 19th of May. This year it will be held virtually, and it will be a de minimis session, which means it will focus principally on the COVID-19 pandemic. The involvement, if any, of observers from Taiwan, China in that assembly is a question for the 194 members of WHO, the member governments. It's their decision. And indeed, a proposal has already been made, as it has been in recent years, for this matter to be considered by the Health Assembly itself. And that is a question which is properly for the member states. But whether or not Taiwanese observers participate in the Health Assembly, there are well-established arrangements for health experts from Taiwan, China, to work with WHO on technical health matters. And I think we've already explained in some detail at previous briefings how that's worked. That last year, for example, Taiwanese experts were included at 8 expert meetings, and that there were 6 other informal technical meetings. And this year, there have been contacts in response to COVID-19 involving Taiwanese experts in key groups and networks. I think we've given details of that on previous occasions. But for this year, as I say, the question is for the Health Assembly. It's for the member states rather than the Secretariat to decide that question. Thank you.
Thank you very much, Mr. Walton, for this explanation. Next question is for Savio Rodriguez from Goa Chronicle.
Hi, can you hear me?
Yes.
Okay. My question goes out to Dr. Tedros. On January 14th, WHO stated preliminary investigations conducted by the Chinese authorities have found no clear evidence of human-to-human transmission of the novel coronavirus identified in Wuhan, China. As an independent global health organization, why did WHO have to rely on China's preliminary investigations into the human-to-human transmission possibility of the coronavirus and not conduct one of its own investigations, is my question.
Thank you.
So I can start, and perhaps others would like to supplement. So the 14th statement that you're referring to is a tweet in which there was the reporting of what had been reported to us from Chinese authorities. I think what is critical and what is important is how WHO acted from the moment we heard about this cluster of atypical pneumonia from Chinese colleagues in Wuhan. From the beginning, I'm the MERS specialist, the focal point at the organization. Mike led the SARS response. And so from the start, whenever you hear of a cluster of an atypical pneumonia, you think respiratory and you think human-to-human transmission. It's not if, it's just what is the extent of human-to-human transmission that may be happening. Within hours of that notification that was picked up through our EIOS system, we activated our emergency systems at the 3 level of the organization, which means our headquarters, our regional office, and our country office in China, where we were having discussions about what we knew, what questions needed to be asked. We immediately posed questions to our colleagues in China to ask for more information, as we do with all clusters or all alerts or all signals that we pick up through the electronic monitoring systems. From the beginning, we assumed that there would be human-to-human transmission, and in our first reporting to our member states and contact points on the 5th of January, it's in our EIS, which is Event Information System, we included detailed information about the cluster itself and also about protecting against acute respiratory infections. We also published on that day our first disease outbreak news. From there, we worked with our international partners to develop guidance, which is around how do you find cases, how do you protect healthcare workers, how do you treat patients, and all of those guidance materials were guidance materials that we adapted from our MERS guidance materials, which included information about how to protect for human-to-human transmission because these viruses are transmitted by respiratory droplets in contact. So our first guidance that was issued was on the 10th of January, which included information about how to protect against human-to-human transmission. So that's important. I did a press conference on the 14th where I did this with Tarek, I described what we knew, and at the time there were 41 confirmed cases. The novel coronavirus had been identified, PCR assays were available in China, and they confirmed that 41 out of the initial more than 100 suspect patients actually had this now we call COVID-19. But at the time we were calling it a novel coronavirus. And so in those 41 cases, described that there may be human-to-human transmission, mainly among close contacts. It's very important that you understand that we receive information from our member states, but we also go back and ask lots of questions. We always do this. It's not unique to this particular situation. situation or unique to China. And we base our actions on what we know and what our experience is in with other similar pathogens, other similar situations. From the beginning, we expected that there could be human-to-human transmission. It was just a matter of how much was actually occurring, where was it occurring. And so initially we thought it would be amongst close contacts through respiratory droplets, and that is still the case today.
Thank you very much.
Just one thing to supplement too, in terms of maybe explaining to people the incident command system at WHO. We operate under a very well-documented emergency response framework, which is an organization-wide framework for managing emergencies. It is constantly under review. And in the process of epidemic or emergency intelligence gathering, we can get up to 3,000 signals a week sometimes that require follow-up. And what we're constantly doing is sifting through the various epidemic signals. We use our own expert networks to do that, seeking information from countries. The systems have AI components for looking for unusual events and picking them out of the background noise. For many outbreaks that occur, we would generally wait for some level of confirmation of the disease before triggering our incident management system for that specific event. We follow every event, but for certain events we trigger the IMS. The IMS is a special mechanism that creates a special and dedicated multidisciplinary team across the 3 levels of the organization and ensures that that event gets a dedicated response for the amount of time it needs to bring the event to an end and to support our member states in that response. That incident management system was established for this event without a diagnosis of the disease, without the virus being known, on the 1st of January. And that IMS has remained in place every single day and has operated as one entity across the 3 levels of the organization since that day.
So just 1 minute, I think it has been covered properly, but wanted to clarify one aspect. The rule we have in WHO and other UN agencies is when a member state reports, we post the member state report as is. So what we did on January 14 in the Twitter is we posted China's report as is. That doesn't mean that we agree or we disagree. We're just reporting what came. Sir, where are you from? The person who asked the question? From India. So if India reports, we post India's report as is. If my own country, Ethiopia, reports, we post the report that came from Ethiopia as is. And we treat the same way all 194 member states. But when we post their reports in our Twitter or website or wherever, we just put it as is, and we don't change anything. But at the same time, if we have some differences with what is reported, as what Dr. Maria Van Kerkhove said, the same day or before even January 14, we can say it. And before January 13, Dr. Maria Van Kerkhove and other colleagues were saying there is a likelihood of human-to-human transmission. But not only that, even on January 14th, Dr. Maria Van Kerkhove and other colleagues were briefing journalists, and they said there is a likelihood of human-to-human transmission. And our guidance reflected all that. And then when China officially reported that it discovered human-to-human transmission, I don't remember the date, was it January 22? On January 22, we just reported again exactly as we received it from China. So that's a normal procedure. And we do it for any country. But that doesn't mean that we accept or not. And we express our own opinion. And the 14th January press conference was carried by many of the major media, including the Reuters, expressing the likelihood of human-to-human transmission. But the most important thing is our guidances before, during 14 January, and after actually included the likelihood of human-to-human transmission that helped countries to prepare. So we want you to have the full picture. And thank you for asking that question. Namaste. It's a very important one which is going around, but this is the whole truth. Thank you.
Yes, and just to supplement again, the DG, again to clarify that WHO has no special powers of investigation or deployment. Every time, and there are thousands of these events every year all around the world, where we're picking up signals, we seek to verify the existence of an epidemic with the country, we seek further information. But we always, on each and every occasion, offer the country assistance with investigation, diagnosis and response, and respond immediately to requests from our member states to do that. And in this case, if we look at, in addition to our 150 country offices, I think we've launched in excess of 80 surge team missions to support our member states already in this response. So we're highly reactive to requests from our member states for assistance in investigation, diagnosis and control, and we do that constantly. And at any one time around the world, we are responding to at least 30 graded emergencies in which we have teams in the field at the request of our member states.
Thank you very much for this explanation. Next question is for John Cohen from Science. John, can you unmute yourself?
Thanks for taking my question. WHO took the lead in organizing an international team of scientists to visit China. Is WHO taking the lead in organizing or pushing for an international team to visit China to study origin questions? And if not, why not?
So I could start, and perhaps others want to supplement. So there have been, indeed, there's been 3 missions to China. The first mission was from members of our China office, our China country office, and members from WIPRO, who went on the 20th and the 21st of January. The second mission, which was with the Director General and Dr. Mike Ryan and others, between the first and the second emergency committee meetings that took place, and that was on the 28th or so of January. And then there was a third mission, which I was a part of, which was the joint WHO-China international mission, in which we had members from many different countries, including Germany, the United States, Nigeria, Russia, I'm going to forget some, but there were Japan, thank you, Korea, thank you. And so we had a group of people who went and worked with our Chinese counterparts. And through those 2 weeks that we were there, we came up with a number of recommendations for China itself, for the rest of the world, for the international community. That report is online, it remains online. It was published very soon after we came back. One of the recommendations, among many, for China was to look at what is the zoonotic source of this outbreak. The public health importance of this is critical because without knowing where the animal origin is, it's difficult for us to attempt to prevent this from happening again. This happens with all emerging pathogens because most emerging pathogens come from animals. And there is discussion with our counterparts in China for a further mission, which would be more academic in focus and really focus on looking at what happened at the beginning in terms of the exposures with different animals so that we can look to have an approach to find the zoonotic source. So that is something that we are working on right now with our counterparts in China, and we have offered support to do that, and we will look forward for that happening.
Thank you very much, Dr. Van Kerkhove. Next question comes from Pearl from Open Parliament. Pearl, can you hear us? Let me try one more time. Pearl from Open Parliament, you would need to unmute yourself.
Yes, thank you very much for your availability and inviting me to today's briefing, Dr. Tedros. I appreciate that. So for the benefit of millions of people who live in autocratic WHO member states and where the democratic space is shrinking for the negative effects of COVID-19, can you share clear data-driven response in terms of lower respiratory infections being ranked second after HIV and AIDS? And is it ahead of tuberculosis? in, say, Zimbabwe? I ask this because although I'm using Zimbabwe as an example in my question, please reply with reference to Mozambique, Tanzania, Zambia, as well as Zimbabwe, given that besides South Africa, in the SADC region, these 4 countries are lagging behind South Africa by many weeks, and no modeling information is readily available to their populations to even talk about a curve. Moreover, in Zimbabwe, the rapid diagnostic test kits...
Can you please get the question very shortly, please?
Sure. I'm about to finish. In particular, OneFo are currently being sourced, and yesterday there was a flurry of debate about their use in that country and their validity. Thank you.
I'm not sure we understood really the question here.
So the question I'm asking is, number one, can you speak to the lower respiratory infections? Are they ranked second behind HIV and AIDS, ahead of tuberculosis? I was using Zimbabwe as an example, but I'm asking you to speak more specifically for Mozambique, Tanzania, and Zambia, and to speak a little bit about the rapid diagnostic test kits, in particular OneFo, which has been used in Zimbabwe.
So these are many questions, so I don't know if any of our experts can...
What I would suggest, your questions are important, but they're very specific to individual countries in Southern Africa. I do know that for the case of Zambia, Mozambique and Zimbabwe, that the reported numbers from those countries are low, but in Zambia there's been a 50% increase in the last week, though the numbers are low. The number of deaths remain low. And obviously in that reflecting a reality, that's positive, but it can also reflect underdiagnosis of cases. So what I would suggest is, given the detail of your questions, that we can try to answer them in writing to you and give you the level of detail that you actually need. Because to compare, I don't frankly know the background TB rates in those 4 countries off the top of my head, and certainly for HIV and other things. But we would be delighted to answer your question directly, and if you can send an email to Tariq and the media team, we'll be very happy to engage with you directly, and I'll be happy to do that personally.
Thank you very much, Dr. Ryan. Next question, Kai Kupferschmidt from Science. Kai, please.
Tariq, thanks a lot. Thanks for taking my question. I'm just wondering, I mean, given that you're the World Health Organization, if you look at the global situation at the moment, can you give us an idea of what the places are at the moment, or the populations that, that right now, you think are seeing, worrying trends, and where you think, the response needs to ramp up?
So that's an important question, but that question needs to be dissected because there are countries, staring at a map as I talk to you, there are countries that are seeing increasing in reported numbers of cases over time. And when we see that, that's a worrying trend. But on the other hand, many countries that are seeing increases in cases have ramped up their testing. And so I don't want to equate countries that are seeing an increase in testing or an exponential growth or a rapid increase as a negative thing. It's not good in terms of seeing cases, in terms of transmission, but I think I don't want to equate that with something that is wrong. I want to equate that with countries are working very hard to increase their ability to find the virus, to find people with the virus, to have testing in place to identify who has COVID-19, and who are putting into place what they need to do to care for those patients. The recommendations that we have for all countries remain the same. Our recommendations include finding all cases, testing cases, caring for cases in the appropriate settings, depending on the severity of their symptoms. Finding all contacts, quarantining those contacts for the full 14 days, making sure that public is fully engaged so that they know what they can do. There is some question about the use of lockdowns or these public health measures. Many countries have had to put those in place because the transmission has increased so rapidly that they were forced to do that. What we have had to do is put guidance out to support countries in lifting those measures, which needs to be done in a controlled way because this virus likes to find opportunities to spread. And if these lockdown measures are lifted too quickly, the virus can take off. And that's a worry that we have. But the question about countries finding cases should not be seen as a negative thing. It should be seen as a positive thing, and we need to support countries through these incredibly difficult times. And as you find cases, the only way to control and suppress this virus, this COVID-19, is to actually find them, quarantine those contacts, isolate the cases, and it will be brought under control.
And if I could just supplement, certainly areas that I would be particularly concerned about, and it's not based on the absolute numbers, but it's based on the underlying vulnerabilities of populations and also the underlying weaknesses of the health system. And this is particularly acute in areas where there's existing humanitarian crisis. And remind you that there'll be an update to the global humanitarian response plan for COVID-19 tomorrow, which we greatly welcome. And when we look at those numbers, and again, they may be small numbers, but again, we've seen in Afghanistan a 76% increase in cases, but also what we're seeing is deaths beginning to increase there by over 60%. Sudan has a 145% increase in the last week, but also tracking increase in deaths of 80%. Palestine similarly with the 100% increase in deaths in the last week. Yemen has a very small problem in the sense of the number of cases that have been reported, but we believe that the virus is spreading at community level, and we need to focus on providing essential health services and COVID-19 services to all people in Yemen, as we do to all people in Syria, and working across lines and ensuring that we are getting and reaching all people within borders, regardless of the different conflicts that are ongoing, is becoming an increasing challenge for the humanitarian organizations. There are other concerns in South America, Central America. There are countries still like Peru and Ecuador that have experienced increase in cases. But again, as Maria said, some of this is down to better testing, and we're seeing more cases. We need to be tracking the proportion of tests that are positive as a way of better tracking that, but also tracking the number of deaths is a good way to really look at that impact. We've also seen in Europe and Western Europe a fundamental decrease in the number of cases, but we have seen a consequent, or not a consequent, but an associated increase in the number of cases reported in places like the Russian Federation. So each region, Southeast, South or the Western Pacific areas, have a relatively are on the downward trend, like Korea and others. But then we do see in South Asia, in places like Bangladesh and India, some trends towards increase. So it's very difficult to say that any particular region is improving or disimproving. There are individual countries within each region that are having difficulties getting on top of this disease, and I am particularly concerned about those countries that have existing ongoing humanitarian crises. Haiti is another one that comes to mind that I would be very concerned about. We need to focus on ensuring that the most vulnerable people in the world get prioritized assistance in this response.
Thank you very much. We have time for one or two more questions. Now I'm calling on Hilary from Business Insider. Hilary, if you can hear us and unmute yourself.
Hi, can you hear me?
Yes, please go ahead.
Great. Yeah, thanks for taking my question. I just wanted to talk about a couple of new reports coming out of France and Florida, some new evidence in scientific journals and via public health departments that there might have been some of the first COVID cases in those places as early as late December. And I'm wondering if, kind of given the speed of global travel these days, if you think countries around the world might have taken a more aggressive approach to some early testing and assumed the virus might have been spreading in their countries earlier.
Thanks for this question. I'm not aware of the report from Florida that you mentioned, but I am aware of the a recent paper that came out. It was published yesterday or overnight on a sample from an individual that tested positive by PCR for now known as COVID-19 on December 27th. In this paper, the authors themselves say that it could be a false positive, but assuming it's not, it is possible that this individual may have had COVID-19 in December. This was about a month before the first cases were reported in France. We need more information about this particular case, if this is a case, to find out the different types of history that this individual may have had. It is possible that there could have been a case in France as early as December. The first symptom onset of the cluster in Wuhan was on the 1st of December. So it is possible that someone may have traveled from Wuhan in the month of December and traveled to other locations, but I don't want to speculate. It's really important that we look further into this. The second thing to mention is that some countries are now utilizing their influenza-like illness and their severe acute respiratory illness surveillance system, which has been established across more than 100 countries for influenza. And they're using those samples prospectively. It started in week 9 of this year and is happening now. And they're testing a subset of those for COVID-19. And that's important because you look for additional cases. Some countries may look backwards and may look at some of those samples that were stored in January or in December and may retest those. So it's possible that we may see some of those samples testing positive for COVID-19, but we need more information from the countries. We need to understand why this individual was tested and how this individual was tested before we can really put this into context.
And if I could supplement, in terms of understanding emerging diseases and new pathogens, what very often happens is that usually astute clinicians or others notice something unusual. They either notice an unusual syndrome. Atypical pneumonia, for example, is not an unusual syndrome. It wouldn't trigger necessarily the system to think there was something wrong. But as happened in Wuhan, the clustering of cases of atypical pneumonia, where the testing that was done was negative for the normal pathogens that you would test for. So you end up in this situation where a group of clinicians looking at cases say, well, we know what this is not, but we don't know what this is. But we still have this cluster of disease that look very similar. And that's what triggers the reaction to say, is this something new? Is there something wrong? And that it's usually a cluster of disease that looks alike. And very often when you then find a test and you go back, you find that not all of the people had that disease. The testing then subsequently confirms only a proportion of them. So when you detected an unusual cluster, what you do is try and find every case of disease, undiagnosed disease, that looks like this, and then you develop a test or find the virus and you go back and test. And that's why some of the cases in China have dates of onset that go back to early December, because as they went and looked at this cluster of disease, and then they go back and test and they say, when was your onset? And the person says, I got sick on the 1st or 2nd of December. But they may have been part of a cluster that was detected at the end of December. So it's not that that person was detected as an unusual case on the first day. They were detected as part of an overall cluster. So from that perspective, it's important to recognize that. In this particular case, I think the clinicians in France and other places very often will do this, and we think this is a very prudent approach. If you have someone with a serious illness and you can't make the diagnosis, very often hospitals will freeze samples as a standard practice, which allows them to come back later and do further diagnostic tests should diagnosis or a new virus or anything else emerge. So it's very prudent that that is done. We look forward to any further examinations that are done by other researchers around the world who may find similar cases. So this is a good thing to do. It's something I think we'll look forward to the peer review publications where we can see that these tests are validated and we can discuss the implications of those results.
Thank you very much. So we will go to last question for today, and that's Gabriela Sotomayor from a Mexican news agency. Gabriela, if you can hear us, please go ahead.
Sí, muchísimas gracias.
Yes, thank you very much for taking my question. I'm going to ask in Spanish. It's for the Proceso magazine. Is there there's a great deal of contrast between the figures that are being presented by the United States with more than 1 million cases and the figures that we're seeing in almost all Latin America, for example, in Mexico, where up until now we've had some 26,000 cases. What is this difference due to? It's a major contrast. We know that the virus doesn't respect borders. Thank you.
So thank you for the question. Yes, there is, you know, as the Director General said in his speech today, if you look at a region or you look at the overall numbers, it doesn't give you the true dynamic nature of this virus in terms of its ability to transmit. Part of the challenge is when you're looking at absolute numbers is that indeed there are absolute numbers. They're not, you could look at them as a rate, as a population-based rate, and then you won't see such drastic differences. Part of it has to do with testing strategy. I'm not familiar with Mexico's testing strategy to be able to comment exactly on how it is the same or differs from other countries. But the numbers of countries that come from cases have to do with the epidemiology and how well it transmits, how hard countries are looking and are able to test. But we really should be comparing rates as opposed to absolute numbers. And if we look at the rates, and I'm looking at a map, I don't have the rates calculated in front of me, it doesn't look as different as these absolute numbers with more than 1 million cases in one country and 26,000 cases in another.
Thank you very much, Dr. Van Kerkhove. We will conclude this press conference, and I would like to thank interpreters who were with us today. Also apologize for some technical issues I understand we had on streams. The audio file will be sent shortly and transcript will be posted tomorrow. I wish everyone a very nice evening.
Thank you, Tariq, and thank you all for joining us, and see you on Friday. Thank you.
Good afternoon and welcome to today's Downing Street press conference. I'm pleased to be joined today by Steve Powis, the Medical Director of NHS England. And before we give an update on the latest figures on the coronavirus and also our work to help support the vulnerable get access to food, today is of course the 75th anniversary of VE Day. And although many of the lockdown measures that are in place and the social distancing measures are in place mean that many of the planned events have been unable to take place as originally envisaged. Today is an important day to pause and remember, and 75 years ago people poured into the streets of our scarred cities to celebrate the end of that most difficult conflict. Our soldiers fought around the world. There were countless acts of bravery. 450,000 British people sadly lost their lives. And it was a moment when our whole country pulled together. As DEFRA Secretary, I would like to take this opportunity to record the efforts of those who also contributed in a non-military way, in particular our farmers who stepped up to ensure that the nation was fed, and the many women who responded to the call to join the Women's Land Army. In a moment, I'm going to give you an update on our work to support the vulnerable get access to food. But firstly, let me give you an update on the latest data from the COBRA coronavirus data file. I can report that through the government's ongoing monitoring and testing programme, as of today, 1,631,561 tests for coronavirus have now been carried out in the UK, including 97,029 tests carried out yesterday. 211,364 people have tested positive, and that's an increase of 4,649 cases since yesterday. 11,788 people are currently in hospital with the coronavirus, down from 12,688 the previous day. And sadly, of those tested positive for coronavirus across all settings, 31,241 have now died. That's an increase of 626 fatalities since yesterday. This new figure includes deaths in all settings, not just in hospitals. And we express our deepest condolences to the families and friends of these victims. Turning now to our work to help the vulnerable get access to food. Firstly, for the so-called shielded cohort, that's those who are clinically vulnerable, over 1 million food parcels have now been delivered to these households. And in addition, all of those on the shielded cohort have been added to a list giving them priority access to supermarket delivery slots. So far, around 400,000 people have been offered priority delivery slots by supermarkets, and around 1 million orders have been placed, ensuring that people can shop normally and purchase the goods that they want to buy. There is, of course, a wider vulnerable group, those perhaps who have disabilities or who are elderly and perhaps don't have neighbours or relatives close by to help them, or indeed those with other conditions that don't put them in the clinically shielded group, but nevertheless make them vulnerable. And we've been working with local authorities and some of the leading charities such as Age UK to put together a package of support to help these people get access to food. And many local authorities and charities have also been accessing the Good Samaritan app as part of the NHS Responder Volunteer Programme. And so far, 79,000 shopping runs have been carried out by volunteers engaged in that programme. In addition, we are continuing to work with supermarkets to make available additional priority slots for those in this group. But we also recognise that the economic impacts of coronavirus means that vulnerability is not just about physical access to food. For some, there is also financial vulnerability. So today, we are announcing a new £16 million fund to support frontline food charities. The fund will be used by Fair Share and WRAP, to continue and support and increase the food redistribution work that they already do, and will significantly expand their sourcing capacity. They will be delivering food to around 5,000 frontline charities, and these include refuges, homeless shelters, and rehabilitation centres. Finally, I'm conscious that there is a great deal of speculation about what the Prime Minister might say on Sunday when he outlines a roadmap for the future and how we will evolve the current restrictions. The Prime Minister will outline any changes to the guidance on Sunday, but in the meantime, in spite of the sunny bank holiday, it is vitally important that we continue to abide by the current restrictions, stay at home to protect the NHS and save lives. Thank you.
Thank you, Secretary of State. I'd like to start by paying tribute on VE Day to every member of the armed forces, and in particular the many doctors, nurses and other clinicians who serve in our military. The NHS was founded as part of the reconstruction of our country after the Second World War, and since it has grown into the most trusted organisation in the country. Along with our armed forces and other public service organisations, the NHS is a rock for people in times of uncertainty. And as we've all found our way through this global pandemic, I'm proud of the partnership that the NHS and our armed forces have forged to give people the help that they need. In constructing the Nightingales, our extra capacity to back up existing intensive care services, the Army and the NHS has worked hand in hand and achieved something quite extraordinary. And I know my colleagues working on the front line of the NHS have been extremely grateful for all the help that the military have offered government in the distribution of protective equipment. So today, as we celebrate the service and dedication of our armed forces personnel, I want to remind those serving in the military that the NHS repays your service with tailored care, whether that's physical rehabilitation or specialist mental health care, in particular to help veterans to make the transition into civilian life. While a growing number of veterans have been referred for help year on year, latest data indicates a drop in the number of people reaching out to specialist services in April. So for any military families watching today, remember that if you need medical help, as is the same for anybody who needs help, particularly emergency help, then please come to us in the NHS. I'd now like to move to the daily presentation of data slides. The first slide is a reminder that I won't go through in detail today because you have seen it many times before, of the 5 tests that the government has set for adjusting the lockdown. In the next slide, we have a slide, as is usual, looking at how the public have been complying with the social distancing instructions that we've all been given. This is data from Google, and it shows a 7-day rolling average of the mobility of the public in various places. And you will see when it comes to transport and retail and recreation and the workplace, there has been a dramatic reduction since the social distancing measures were introduced. A little bit of an uptick in workplaces, but I would remind you that people are clearly working in some workplaces, although many are working from home. One other thing to point out, in parks, you will see that there's a bit of variation in use of parks, which I'm sure is consistent with sunny weather and people going out a little bit more. In the next slide, we look at the daily tests. You've heard the data for yesterday, and you will see